So let me just kind of start out on behalf of the NAS. Thank you for jumping on this Zoom call with us today. In today's changing world, unfortunately, we can't all be together at in-person events where you are currently, but being here virtually is the next best thing. So we are excited to do this today with one of our leading experts in infectious disease, Dr. Ned Hook. I'm going to tell you a little bit more about him in just a few minutes, but I want to just give you a couple of the ground rules. We will have everyone muted. So at the end, when we ask for questions, if you want, you will have the ability to unmute yourself or to raise your hand, and we can acknowledge you that way as well. Or you can put your questions into the chat box, and he will be able to see them there and can answer them as well. So let me tell you a little bit about Dr. Hook before we turn the discussion over to him. Dr. Hook is an emeritus professor of medicine at the University of Alabama at Birmingham, where he was previously a professor of medicine and microbiology in the School of Medicine and a professor of epidemiology in the School of Public Health. He earned his MD from Cornell University. As an internist with subspecialty expertise in infectious disease, much of Dr. Hook's academic career has been focused on management and prevention of sexually transmitted diseases. In this context, he has directed public health STD control programs in 2 cities, Birmingham, Alabama, and Baltimore, Maryland, directed clinical studies with operational and epidemiologic endpoints, directed clinical trials of new diagnostic tests, vaccine, and therapies for a wide variety of STD pathogens, and directed an internationally recognized reference laboratory for STD pathogens. Dr. Hook was previously the medical director of the Sexually Transmitted Diseases Control Program at the Jefferson County Health Department in Birmingham, where he remains a contract physician. He has served as a consultant and committee member for a number of national and international organizations, including the National Academies of Science, Engineering, and Medicine, National Institutes of Health, Center for Disease Control and Prevention, and World Health Organization. Before joining the University of Alabama at Birmingham, he worked at Johns Hopkins University and with the Baltimore City Health Department. Dr. Hook has authored over 330 peer-reviewed papers, 50 textbook chapters, 40 editorial documentaries, and 4 books. Like most in the Division of Infectious Diseases, as part of UAB's response to the COVID-19 pandemic, Dr. Hook has been involved in the process of approving or disapproving testing, answering clinical questions, and is actively serving as a COVID consultant to several major regional utilities and businesses. Dr. Hook will summarize UAB's extensive and expanding research portfolio related to COVID-19. So with that, thank you, Dr. Hook, for being here, and I will turn the floor over to you.
Thank you very much, Dr. Breland, and thanks to all of you out there for joining us by Zoom. I know we all wish it were in person. What I thought I would do today is have 3 relatively brief sets of comments for you, and then I'd like to follow up with questions and answers, which I actually think from past experience are the most important part of this presentation. Before I get to that, however, and perhaps in anticipation of some of the questions, I'm going to very, very briefly provide a national and regional overview. Then I'm going to importantly talk what are today's hot topics. That is, what's new with regard to this, what's different, what do we think's happening, what can we be on the lookout for in terms of more information. And then finally, before we get to Q&A, I'd like to engage in and briefly describe at least some of the types of COVID-19 research that are ongoing here at UAB. I won't provide specific data since
looking at your wall. Oh yeah, I knew that.
I won't provide specific data on. I'm sorry. I think somebody needs to mute their phone. I won't provide specific data on those trials, as many of them are ongoing, but we will talk about them and the types of trials and where we think they're going to go. So that's what we have in store. I'll encourage you, as I make my comments, to go on and use the chat function to list your questions so that I can address the things that are on your mind today. First, regarding where we are with this epidemic, unfortunately this week we crossed a sad threshold, having diagnosed over 1 million Americans with COVID-19. That number, as enormous as it is also even more daunting when we realize that this is an underestimate. We don't know exactly what the proportion of asymptomatic persons with infection is. Some people say it may be 20 to 25% of patients. Some people say it may be as many as 50% of people who are infected. Irrespective, that means all the numbers, wherever we are, conservative in terms of the number of persons who have this infection. Furthermore, just today we crossed yet another sad threshold with more than 59,000 Americans who have died from this problem in just the last 4 months. By way of contrast, I would mention to you that now exceeds the number of people who died during the Vietnam War in over a decade. What about infections here in the southeastern United States? And I know there are people on the phone from Georgia and the Nashville area, as well as colleagues there in DC. But in Atlanta, Nashville, and Alabama, we've been pretty fortunate. We didn't have the sorts of explosive outbreak that occurred in the New York area, and we were therefore able to get control measures in place which have at least damped down the occurrence of these infections. That doesn't mean that we're not going to continue to see increasing infections, and in fact, in many areas now across the nation, we're beginning to embark on an experiment of sorts in which we're beginning to ease off some of the restrictions that occurred. I would point out that the reason we had those restrictions to start off with in terms of shelter in place and the like had to do not with efforts to necessarily end the epidemic, because we're not going to do that, but instead to avoid overwhelming the healthcare system. And I think in most places that seems to have occurred, and that's part of the reason we can begin to take steps to reemerge from our shelter-in-place status. More on that shortly. I do think, however, that it's also important to realize that here in this country, we have never had enough tests. We have still tested less than 2% of the American population. So, 3% of the American population. So that that million people really reflects only a fraction of the potential infections which might be occurring. I think looking into the future, what we can anticipate is that as testing becomes more available, we will also continue to see new infections. We're going to have this infection with us for the foreseeable future, barring some sort of remarkable therapeutic breakthrough. I don't think vaccines are going to occur anytime in the next 6 to 9 months. 12 months would be a very optimistic outcome. So what are the hot topics with the epidemic today? Well, there are 5 topics I want to deal with. The first, of course, is therapeutics. We've heard a lot about therapeutics. We're interested in that. Everybody on the phone, I'm sure, had occurred and is aware that Plaquenil or hydroxychloroquine, given with or without azithromycin, has engendered a lot of interest early on in the epidemic. I'm sad to say that while the randomized clinical trials data are not currently available, the growing data and sense is that that's not going to be highly effective for treatment of this infection. In contrast, the antiviral agent called remdesivir, which we at UAB are particularly proud of since it was developed in part through a collaboration with UAB and Southern Research Institute here in Birmingham by Dr. Richard Whitley and his colleagues, may be promising. This is an antiviral agent. It's effective against the SARS virus and the MERS virus, two related coronaviruses. And just today, the manufacturer, Gilead, said that while they don't have the full data currently available, it's their sense that there may be positive results. I think you can expect to see a press release from the National Institutes of Health. Perhaps it's early, certainly sometime this week. Let's also remember that remdesivir, while it would be a wonderful thing for hospitalized patients, is probably not going to be a game changer for those of us walking around. It's been studied only in the sickest patients. It's an infused drug, so that it requires injection for administration. Lots of other therapeutics are being evaluated for a variety of different purposes. I'll mention a little bit more about that in my comments regarding UAB research. I think the hottest topic in the area that's getting the most attention in the last 48 to 72 hours is the fact that across the nation, in those places where there have been shelter-in-place guidance and recommendations, that people are beginning to take steps to unwind it. And so we need to think about that. And I think, as I said earlier, what we're embarking on nationally and regionally from place to place is an experiment where we're going to be watching closely what happens as we begin to liberalize some of the guidance. I think liberalize is the key word to those statements. We are not going to get back to the way we were in February of 2020. We're going to continue to have to use social distancing, hand washing, all of those sorts of things that we are trying to do to reduce the spread and rate of spread of this infection. The shelter-in-place movement many places are adopting is a stepwise position in which, for instance, here in the state of Alabama yesterday, our governor announced new guidelines in which she has permitted opening of shops and businesses which were deemed non-essential before. We still are not permitted to have our restaurants, gyms, hair, barber shops, hair salons, etc. open. But the fact that the shops have been opened and that they're now allowing groups of up to 10 people to aggregate has to do with the confidence that we've begun to curtail the spread of this infection. An abiding question as we move forward in this is just what is the right geographical unit to implement these efforts in. Here in Alabama, I can tell you for a fact that county by county unwinding is probably not the way to go. And the reason for that is because we live in a mobile society in which people travel from county to county and place to place for work and other activities. States may be a correct area or regions, and we certainly know that while those of us here living in the southeastern United States have not adopted a regional practice and have variation on a state-to-state basis, that certain parts of the country, the Northeast, Midwest, and West Coast, all have decided to do a collaborative and regional process by which they begin to unwind their restrictions and activity. What is the goal of this? I think it's also important for us to think about that. Let's all remember that the goal of all of these efforts was not to stop the epidemic. We don't believe we can do that. It was to temper it, to not overwhelm the health system. And what that means is that what all of us need to anticipate, because I think it's going to be a fact of life for the next year or so, is that we're going to continue to see new COVID-19 infections. We're going to see people die from this, and from time to time and in place to place, particularly places like long-term care facilities, nursing homes, and perhaps these dense workplaces like packing houses and so forth, we're going to see outbreaks, and that's just the fact of the matter. How bad, how extensive, and how to best manage them is an evolving target that we don't have complete answers to at this time. I also think as we begin to stepwise unwind and liberalize the shelter-in-place guidance, we need to embrace the social issues and realize that the reason that we're doing this shelter in place, the reason that, for instance, here in the city of Birmingham, the city council just passed a law yesterday saying that individuals are mandated to wear face masks when out in public, and if they don't do that, they'll be subject to a fine. And those sorts of issues, irrespective of what you think about them, do embrace the issues of both trying to keep people from acquiring the infection and also keeping those who are infected from spreading the infection to others. The business of preventing spread to others is actually probably an easier task than preventing acquisition of infection. More on that perhaps during the Q&A period. A third hot topic has to do with test performance. I think there is beginning to be a literature and concerns about test performance regarding the PCR test to detect this virus. There are just a couple highlights that I'd like to bring up on this. First of all, there are a variety of different tests and they all have different performance characteristics. But so far, most testing, because testing is limited in its availability, has focused on people with designated symptoms. And you all know that those symptoms were expanded by the CDC yesterday. But as long as you're predicting people with symptoms, you're testing a group of people who are particularly likely to be infected, and that really does make your test performance data look better. As we begin to test people with a broader and broader number of symptoms, or even people with no symptoms at all, we can expect to begin to see the impact of occasional false positive tests, and that's just a fact that we are going to have to deal with. I also think that as we think about test and test availability, we're beginning to have access to tests, at least for symptomatic people in most of the country. And so there's another variable that's important for all of us as healthcare providers to think hard about, and that has to do with turnaround time, because there's still a huge amount of variation in test turnaround time. There are some places here at UAB, every patient coming into the hospital is tested for COVID-19, and we have their test results in less than 24 hours. On the other hand, doctors' offices, clinics that are sending out results, some instances, it can take 3, 5, or even 7 days for test results to come back. And obviously, that's a crucial consideration because it's based on the test results that we want to make decisions. There are point-of-care tests that are available, but those point-of-care tests are very low volume. And so while they may be useful in emergency rooms or in selected settings, I don't think they're the complete answer to this. A fourth hot topic is that of antibody testing, that is serologic testing. I think there are beginning to be more and more tests. The tests that are available, however, have generally not been carefully scrutinized, and that's a problem because we know that many of the antibody tests do have a tendency to cross-react with other coronaviruses. Please remember that coronaviruses as a group are the cause of the common cold. What's different about this coronavirus is that until 4 months ago, human beings had not had it. And so there's no immunity, and that combined with its aggressiveness and high degree of transmissibility is where the reason we're in the fix in the situation we're in right now. I think as we begin to see serologic studies of antibodies to COVID-19, we'll begin to get a better picture of just how widespread this infection is. But I think no matter what it is, even in the most intensely affected communities, the seroprevalence of antibodies to COVID-19 has never exceeded 20%. And that's far from the herd immunity that will be needed to truly control this ongoing epidemic. I also think the issues of stigma as they affect people either with or without antibody tests that are positive for COVID-19 or something that we may be hearing more about and is currently unexplored. The fifth hot topic that I just want to briefly acknowledge, although we don't know an awful lot about it, is contact tracing. We know that that's an essential part of our efforts to control this, that we know that this virus is most infectious in the 48 hours before people who become symptomatic develop those symptoms. And so alerting people so that they can take precautions and quarantine while they wait for a test or wait for the development of symptoms is going to be an important element of control. The government has started talking about hiring a group of professionals who would do contact tracing, but no matter how you do it, given the scope of this epidemic, I also think that issues regarding notification by individuals will play an important part of this evolving picture. So that's something I would encourage people to keep their eyes on. What about UAB and UAB research? Well, like almost everywhere in the United States, we did not have a COVID-19 research program here at UAB even 2 months ago. That's all changed. We're now engaged in a number of different studies regarding this virus. We are participating in NIH-sponsored studies of both remdesivir and hydroxychloroquine, both alone and in combination with azithromycin, to evaluate therapeutic outcomes. We also have ongoing clinical trials to evaluate the effect of nitric oxide gas for patients on ventilators to try to avoid the progression of the acute respiratory distress syndrome. We have ongoing trials of drugs designed to minimize or temper the cytokine storm, which is becoming part of this. And just this week, we've started to treat patients with convalescent serum from patients who've recovered from the infection. So there's a lot of therapeutic research going on. In our Department of Microbiology, we have ongoing research regarding vaccines. The first step to a vaccine, of course, is to see if it protects in experimental animals, and those mouse studies are ongoing in the Department of Microbiology. And then finally, one of our great strengths at this institution are our epidemiologic studies. And one of the other great strengths of UAB as a health center is that it does an enormous number of organ transplants and solid organ transplants. In fact, UAB does the second most kidney transplants in the entire United States, for instance. And for all those reasons, it makes it obvious and makes it appropriate that here at UAB, we're involved in studies to describe the course of the disease in persons who've received solid organ transplants. We also, our great Department of OBGYN is started a registry regarding pregnancy outcomes in persons with coronavirus. We're participating as one of many institutions in studies of the clinical and epidemiologic features of this infection. And another, in our HIV group, we've received a considerable amount of notoriety for our ability to look at the outcomes, long-term outcomes, health disparities, financial impact of HIV, and now we've extended and used our knowledge in those areas to address the consequences of COVID-19 as well. So that's just an example, a taste, if you will, of the sorts of things that are going on here at UAB in terms of the COVID-19 work. At this point, I've sort of talked continuously for about 25 minutes. I would welcome your questions. Please use the chat function to ask the questions, and I'll be happy to address as many of them as possible. While we do that, we have received a few questions from folks by email before the actual meeting began, and let me address a couple of those right away. One is there a danger from the virus being in the air if I walk in my neighborhood? Can I go outside? Can I take walks? The answer is yes. I think, again, we need to think about this. The greatest and best analogy for the situation is influenza, because this virus is transmitted in similar ways. Unfortunately, it's more infectious and more deadly. We think about 0.1% of people who get influenza die from it. As with COVID-19, it's the elderly who are most likely to have those consequences. COVID-19 is at least 2 to 3 times more infectious than influenza, and probably 10 times more deadly as an infection. But walking in the neighborhood in the fresh air makes it unlikely. We all know, and again, by way of analogy, you've all had the experience of being in contact with friends or relatives or patients who have had influenza, and yet you've managed not to get it. Well, the same is true for COVID-19. Most people who are exposed will not get it, but there are also very important things that each of us can do to reduce our risk further than average, such as good hand washing, social distancing, and in many settings, masks. Another question I got was from a physical therapist who works with patients in an orthopedic clinic. She works on patients one-on-one, but the nature of physical therapy requires direct contact. Any suggestions about what to do? And absolutely, physical therapy is an important part of the healing process. And here at UAB, we're beginning to do elective surgeries now, so we will need our physical therapists more and more. And the answer is lots of hand washing, masks on both the physical therapist and the patient, and that the patients should not be coming for physical therapy if they're otherwise feeling ill. That is, with a cough, a fever, shortness of breath, muscle aches, the symptoms that we use to guide testing for COVID-19. One other question that I got that I thought was quite interesting had to do with somebody whose fiance had COVID-19. The questionnaire developed symptoms of shortness of breath and fever and had a test, and the test was negative. And so the question was, did I have COVID-19 or not? Do I count as a case? The answer to those questions is yes, you probably did have COVID-19. Your test may have failed to detect it for a number of reasons, and I'll mention that in just a moment. But you will not be counted in terms of the cases of COVID-19 that are described. So how could somebody have the infection and not have it detected? Well, there are a number of issues. One is that there are no perfect tests. So although good, well-made PCR tests are extraordinarily sensitive, there is test-to-test variation in sensitivity. Secondly, the quality of the specimen collected has impact on test performance. Remember that the best possible specimen for a COVID-19 test is a PCR test performed on a swab, which is inserted through the nostril all the way to the back of the throat. That's a long way. It sounds awful to hear about. And while it's not quite as bad to experience, it's nobody's idea of a good time. Unfortunately, for that reason, sometimes people will have inadequate specimens, and that too can lead to negative test results. The final thing is to remember that many people who develop symptoms of COVID-19 will continue to be symptomatic at a time when they're no longer infectious. The natural history of this virus is that during the 48 hours before a symptomatic person develops their symptoms, they are excreting large amounts of virus and are highly infectious. As symptoms begin to occur, and remember that symptoms represent the body's efforts to fight off an infection, as symptoms occur, infectivity goes down, and that the symptoms from COVID-19 can last after persons are no longer infectious. That does lead me to the second tip, which is that we have strong evidence that very few people, if any, are still infectious 14 days following the onset of symptoms of COVID-19. Despite that, follow-up tests could be positive because of residual dead and non-infectious virus that's present in the specimen. So we're not, here at UAB, we're not routinely recommending a follow-up test to make sure the virus is no longer present. One other question that I have before I get to the questions that I see in the chat box is, what about warm weather? Is it going to make the virus disappear? Or are we going to get rid of it that way? And the answer is it's likely to reduce the amount of disease because it gets people out, because sunlight and warmer temperatures are deleterious to the virus and its potential infectivity, but it's not going to make the epidemic go away entirely. So, looking at the chat room, I see one question from Greg Berry. Greg, thank you for your question. You mentioned that the current norm will be around for some time, upwards of 18 months. What's realistic time frame for our old norm to return, if ever? Has this changed our world forever? Boy, what a great question, and I could answer it better if I had a highly functional crystal ball, but I'll tell you my own personal estimate about that, which is that if we're successful in developing a vaccine, and I think the biological characteristics of this virus are such that it's probable that it should be a vaccine preventable disease, then we may be able to get back to our old norm and not have to worry. And in one of the other alumni talks that I've done for Dr. Breland, we got down to really the heart of the matter for people here living in the Southeast. How's this going to affect college football? And the fact of the matter is, it's going to be hard to get together with 100,000 people in September to watch a football game. And hopefully, with an appropriate vaccine, we'll be able to move that forward. The other part of that, of course, and this is as much a social phenomenon as otherwise, is if we get an effective vaccine, are we going to be able to get everybody to take it? We know that there is a strong anti-vaccine movement here in the United States. They don't trust vaccines. We also know that when people as a group fail to take vaccines, you get to above a certain number, those people who are not getting vaccinated not only endanger themselves, but endanger the whole community because they can spread the virus to others. So that's going to be an important question. So not a specific yes/no answer for you, Greg. In fact, somebody once said that I've never answered a yes/no question with less than a paragraph. That's the case here. But on to the next question. Keith Marks has a question. He says, if someone contracts COVID-19, once they recover, are they now immune? That's certainly that's a great question. we don't have direct data, but that's the assumption. We're going to have more data from that, Keith, in two different ways. One is by these ongoing studies in which they're administering immune serum to patients with the infection in randomized clinical trials to see that if they can alter the course. If they can, that'll probably provide the first evidence that we do have lasting protective immunity. The next part of that question, of course, is that immunity 100% or is it partial? No way of knowing the answer to that. And we do know that there are several reports of people who've acquired the infection more than once. Not enough that we really understand the natural history or the meaning of that or the relationship. But the assumption is that people who've recovered can take a degree of comfort that they're less susceptible to the infection than others. Okay, our questions are beginning to pick up. Claire Jackson has a great question. Do I expect to see a resurgence as things reopen? You know, reopening, Claire, means different things in different states, and so that's point one. I think we will continue to see infections. Remember that part of the criteria for reopening, we would prefer to see a decline in number of cases, but that's a decline in the number of new cases. So it doesn't mean that new cases aren't occurring. And I think as people get out, are mixing more, we're going to see infections. And the question is, what is that equilibrium going to be? Just how many infections are we going to have? I do think that we will have to keep an eye on that. And again, I think many of our different states and regions are each engaging in their own sorts of experiments. Here's another question. Kelly Hill says, any advice for someone who works in a dental setting, particularly in an office that sees lots of children, considering the likelihood that children are asymptomatic carriers? Also, any advice for teachers and daycare workers? Oh, boy, I wish I had the answer for that. You know, you're very kind, Kelly, when you say the likelihood of children being asymptomatic carriers. Some people are just calling them vectors. I think that we do know that children do get infected with this. There's some debate as to whether children are a little less susceptible than adults or just have different outcomes. But I think the risk, daycare settings, dental offices, and so forth are substantial. In fact, amongst healthcare workers, the people who are at greatest risk are certainly dentists. I wish we had a better answer for that, but we're going to have to keep our eye on that. Brian Coley says, as a flu-like virus, will a vaccine also be flu-like, meaning does it have to be administered annually? Boy, that's a great question as well. We simply don't know the answer to that. Step one is to get the vaccine, see if it works. The good news, however, is that there's at least a reasonable theoretical possibility that the vaccine will have a lasting benefit. The reason for that is that the influenza virus is directed at two components of the virus, and those viruses evolve very rapidly and annually on a regular basis. The coronaviruses and the data that we have from coronaviruses that have been seen over the last 3 or 4 months across the world is that the rate of genetic evolution of this virus is much, much slower than influenza. So if we're lucky, one injection will be enough. Greg Berry has another question. As a father of 3 teens, am I okay to allow my kids to hang out with their friends as long as they stay 6 feet apart and in groups of no more than 10? Oh boy, Greg, that's a great question, and I don't know the answer. I've got 2 daughters who are now just out of their teens. I think one generalization that I've seen is that younger people in our communities as a group, and there are obviously exceptions, but as a group, are not as worried about this infection as we are as adults, and so they sometimes are not quite as good at social distancing and not gathering in groups. I think the best we can do, having survived my daughter's teenage years when they regularly seemed to be amazed that I could walk and chew gum at the same time, I think that what we have to do is do our best to instill in them the sense of social responsibility, because they could get the infection, take it home, and infect others, whether that's us or their grandparents or other people around them. We're all in this together. I think that, but I think it's going to be very, very tough to keep young people from getting together. I think I know what the recommendations are, but I think I'm trying to be practical in my response here. Jennifer Glenn has a question. What are my thoughts about all of the conspiracy type theories regarding importation of cases, inflation of the cases reported, and the idea that all of this is being blown out of proportion? Well, that's a great question, Jennifer, and I think the numbers speak for themselves. Remember that influenza in this country very reliably kills 10 to 20,000 Americans. We have that's each year, each influenza season. Influenza season is typically 6 to 8 months. In less than 3 months here in the United States, we've got 60,000 dead people. I think those results are a conservative estimate, so I think those conspiracy theories are off base. Remember, though, that 60,000 deaths in a country of 300 million people is still a small fraction of the population, and so it's a little bit of a risk-benefit kind of question as we move forward on this. But I tend to not buy into the conspiracy theory issues. Tanisha Perryman says, when we return to our offices where there are more than 1,000 people, we're sitting all days at our computers. What do preventive measures look like? Oh, that's a great question. And in fact, in my consultation activities for a number of essential businesses here in Alabama and in the Southeast, we've worked through those a lot. So I'll be happy to address that. First of all, you'd like to continue to have some degree of social distancing. Many people work in cubicles or carrels that are next to each other. They're not quite 6 feet apart, person to person. It's more like 3 or 4 feet apart. I don't know if that's enough or not. It's better than nothing. I think in crowded office, one way of addressing that, however, and one thing that I can tell you for a fact that a number of businesses are doing is that they're still strongly entertaining the possibilities of a changed work week, having flexible hours. Morning people might come to work at 6 o'clock in the morning rather than 8 or 9 o'clock, and other people who are night people might show up around noon. They have to get their work done. I think there'll be more liberal policies about work from home, and in some places as they begin to open up, what they've decided to do is have an altered work week to get people back into the workforce, at least in part. We're sort of dividing the workforce into a Monday, Wednesday, Friday, and a Tuesday, Thursday, Saturday work teams and trying to address that. Within the workplace, the other thing that's really important to consider here about this is the water fountain is the enemy, the Xerox machine is not your friend, shared telephones are not good, and break rooms where we sit together without social distancing are not going to be helping us. I think that we have to think as we move forward. One of the things we instituted in the very early parts for some of our initial construction partners were that food trucks weren't really good, because when the food truck arrives, we all go and stand in line close to one another, and if anything, we worry too much about whether somebody's going to get in front of us, so we crowd together. So I think that at least one potential safety measure, which will be helpful, is to do your best to think about bringing your own lunch, bring your own water bottles. Don't drink out of the water fountain, please. Those are steps, and again, as I've said repeatedly, and unfortunately, this is part of an experiment for all of us. Great question. Like so many of these things, Ms. Perryman, I don't have all the answers, and I think we're going to have to keep an eye on it. Jill Kell, I believe, or Kell, I believe. I hope I didn't butcher it too much. How realistic do I think it'll be for children to return to school this fall, given the difficulty of social distancing among children? And Jesse Arnittis says much the same question. Do I think there will be classes on campus at UAB this fall? How will UAB work with residential? Dining commons, question mark. Those are both related questions. I think the schools will open up. I think the president is pushing for it. And I think that you can talk, and I think the research will show that while homeschooling is better than nothing, it's not as good as the classroom interactions and those kinds of things. I think we will be getting back to school, but exactly what that's going to look like, it remains to be seen. I think gym class is probably done for. I think current recommendations for, in some instances, when people go back to school, is that lunches should be served to kids in the classroom, not in the cafeteria where they're going to mix and sit together. But I do think they are going to be we are going to be having classes in some manner, shape, or form. I suspect the classes, particularly when we get into the college and graduate level classes, and maybe even some of the high school level, will begin to have a more prominent distance learning component as well. I think, I don't mean for it to sound as cavalier as it's going to sound, but I think the fact of the matter is, with all this stuff, we're taking the best information we have from other experiences and then making it up as we go along. So you've had a bunch of really great questions. I wish my answers had been as good as your questions, but they're really thoughtful, and they really do a great job of showing us the spectrum of activity and so forth. One of the things that I do is that as my day goes on after one of these calls, I continue to think about it. I'm going to return to a question that Tanisha Perryman asked about when we return to crowded workspaces. What do we do? Tanisha, the other thing that's going to happen, and this is related to that. What do we do about carpools? What do we do about buses and transport? And I don't think we've got those answers yet, but I think that carpools, buses, public transport do represent relatively higher risk venues for transition. And I don't know what the answers are, but I wanted to acknowledge that as another element of the questions we deal with. All right, Dr. Breland, I've been engaged with a monologue here for going on an hour. I haven't seen any new questions, so I've either worn everybody out or bored them to death, but I do hope that at least some of the information I've provided to you has been helpful. I also want to thank the Alumni Association for the opportunity to talk to you, and thank you for your participation as part of our great institution.
Thank you so much, Dr. Hook, and thank you everyone for joining. This was so informative, and I really hope everyone got something out of it. I know I certainly did. So thank you again, Dr. Hook, for taking time out of your busy schedule to talk with us, and thank you to everyone. We hope to see you soon.
Thanks very much, Claire. Everybody stay safe. Have a great day. Take care. Bye now.